Donc, bonjour tout le monde, bienvenue à la conférence mensuelle du mois de mars. Je m'appelle Julie Gauguin, je suis la directrice adjointe aux études supérieures et à la recherche ici au CFMNB. On est vraiment chanceux d'accueillir le Dr. Paul Atkinson aujourd'hui avec sa présentation de la crise à la compassion. So thank you so much for joining us, Dr. Atkinson. We're really lucky to have you here today. And we're very blessed from our partnership that we have with you, Dalmed NB. So Dr. Paul Atkinson wears many hats. He is a professor of emergency medicine at Dalhousie University and chief scientific officer at Horizon Health Network. He also serves as assistant dean of research at Dalhousie Medicine, New Brunswick, deputy editor of the Canadian Journal of Emergency Medicine, and chief medical consultant for WorkSafe NB. Originally trained at Queen's University, Belfast, Dr. Atkinson completed postgraduate training in internal medicine in Belfast and emergency medicine in Cambridge, UK, followed by a fellowship in Sydney, Australia. He has lived and worked in Canada, fortunately for us, for the past 16 years, contributing to research, education, and health system leadership. He has authored more than 200 academic publications and contributed to several medical textbooks and international curricula. His work has been recognized with multiple awards, including the Canadian Association of Emergency Physicians ENCL, I hope I pronounced that right, Researcher of the Year Award. Dr. Atkinson's work focuses on improving healthcare through research, medical education, and system innovation, with a particular emphasis on prevention and health system improvement in New Brunswick. So without further ado, Dr. Atkinson, thank you so much.
Bonjour tout le monde. Merci beaucoup, Julie, Essayed, pour l'invitation. Je suis très content d'être ici avec vous à Moncton aujourd'hui. Mon français est très limité. Alors, pour votre confort et votre sécurité à la Air Canada, je vais continuer en anglais. Merci beaucoup. It is really a pleasure to be here. And thank you for that introduction. I always wonder who the person is talking about when they're talking about me, but I guess over time you do put on lots of hats and take off some, and hopefully overall contribute to moving things forward. It is a real pleasure, and I also value the relationship that we have here within New Brunswick between our different institutes, our different universities, our health authorities, and I do think that we're really beginning to move to working more closely together. So thank you for this opportunity today. Before we dive into the topic at hand, which is dear to my heart, I do want to acknowledge the land that we're on, but also, I think, as importantly, the traditional knowledge keepers, young and old, that have been here before us, and that we can learn from all around us together. You mentioned much of this. I just wanted to put this on my disclosure slide that, yeah, I've got lots of different roles. I'm very proud to have contributed to these textbooks and continue to contribute to the literature, both myself and as an editor in a national journal. But I do have to acknowledge that I do get paid. We all get paid. And I am paid by these three institutions, Dalhousie University, WorkSafe New Brunswick, and Horizon, though today, really, my comments are more my own personal comments, but I do feel that I also represent the cultures of the organizations that I work for, but I've no direct financial conflicts to declare. Over the next few minutes, I'm not sure how long this will take. I hope it's not going to go over our time. I'd like to dive into some of the evidence around why compassion is important in our healthcare systems, examine some of the barriers to this, maybe look at some of the approaches that we can take. And as we go through, I will be highlighting, since it's a research environment and a research talk, I do want to highlight some of the work that we have begun to research in this area. You mentioned that I do hail from Northern Ireland or the north of Ireland, depending on your political bent. Here's a picture of the university I went to. This is not the medical lab, I can assure you. But I love the old universities of Europe certainly did did do a good job on their main buildings and their quads. Really enjoyed my time at Cambridge. I was there for 11 years and learned a lot. Learned really how to think. I think that was one of the things that Cambridge really did. You got challenged on every statement. It was not a place where you could get away with things, making it up. You really were challenged to try to back up your thoughts and your statements. A year of fun in the sun in Sydney was also good, and really started to get me thinking about what I wanted to research and what areas I wanted to research in, and then ended up here in beautiful New Brunswick in St. John. Maybe it can't compete in terms of the buildings or the sunshine with some of the other places, but in terms of the warmth of the people and the opportunity, I think, to work in smaller communities and work together, I think it's hard to beat New Brunswick. So I'm very proud to be here. And again, before we jump into the talk about compassion, I thought it might be useful, just since we're um, developing our connections between our two medical schools, to just outline in brief how we organize research here within Dalhousie Medicine New Brunswick. So we have a research council, and I'm hoping that as we move forward, there will be involvement and collaboration at that level between both our universities. The council is a grouping where we think strategically and we think about partnerships with different institutions. Beneath that council, we have three main groups, research groups, and we have the Discovery Research Group, which is, I guess, what we would call our wet lab folks, are people down in the basement who operate a really state-of-the-art facility. And we have several PIs there and many grad students working away on pharmacology and biochemistry and other approaches. We partner with UNB there as well. We have some members from their Institute of Health who work in our lab and have their students there. And we have great staff there. So a big shout out to the great work that's ongoing there. We also have a group that focuses in on population health, and this includes epidemiology, community health, as well as occupational medicine, and it partners again with our folks in public health and at UNB, at the Institute of Population Health. And this is a great group in terms of connecting around big data sets and how the health system works. And then finally, we have our clinical and medical education research group, which again does what it says on the label. It focuses in on supporting faculty who are involved in clinical research and medical education research, whether that's supervising learners or actually researching the elements of how to teach. Now, I do want to say that I'm also now in the role of Chief Scientific Officer at Horizon, and I'm hoping that these connections and ties will strengthen. And I do think that the clinical component of research and the innovation side will really begin to take off here in New Brunswick, as now both Vitalite and Horizon have created institutes that will help us focus in on research and innovation in the clinical space. So that's an exciting time. But I want to just take a moment now and think about that environment for the rest of today. So I do value our discovery research, our population health, but you know, at the core of it all, I'm a clinician and an educator, as well as a researcher, and so I want to focus in on this area of clinical practice and the research to support it. Now, as Julie mentioned, my primary specialty is emergency medicine. My secondary specialty is occupational medicine. And those actually come together and are coming together more and more recently. So, anyone recognize the show? I'm sure many of you have tuned into The Pit. It took me a while. I have to be honest. I really struggled to get myself onto, not because I couldn't find the channel, but just because I didn't really have it in me to go watch more of the work that I have done for many years in a clinical environment, because it was actually becoming quite upsetting. And I think there's a theme that resonates through the pit, which is the stress on the staff as well as on the system. The system isn't great. The system is under pressure, but so are the staff. And here is the very opening scene of the first episode of The Pit, where we see a physician standing on the wrong side of the rails on top of a building, which is never a good position to be in. The healthcare system here in Canada is not doing very well. Here's a National Post article that quoted some of our research. The lifeboat is full. Canada's healthcare system is failing. There's no easy solution. Sure, but there are some solutions. I did spend many years pointing out the concerns, the
I have it
problem.
marked down for tomorrow.
I think we've got someone
if I had to say it ahead of you,
not
so you never
muted
say
here.
it out.
Sorry about that. So as I was saying, the lifeboat is full. The lifeboat is the emergency department. The lifeboat is the part of the system that is there for emergencies. When you fall in the water, when you have an unanticipated illness. But even now that is full, and I'm thinking that it has almost become the boat at times, that people have to go try to get into this overfull lifeboat just to get routine care. So we're facing trouble. And it's not that this is just inconvenient. Here's a paper that we published back now in 2023 that analyzed death rates in Canada. And the sad reality is that between 8,000 to maybe close to 11, 12,000 patients, it's estimated from our statistics, die because of the long waits to access urgent healthcare system. So that's important. So there are thousands of patients dying in Canada. This is not just about long waits. It's not just about the odd case that we hear that dies in the waiting room, but there is this hidden epidemic of death, of increased mortality because of our overburdened system. And it's not all just in the emergency department. For those of you who are in other specialties, I get it. It's the whole system is backlogged and overburdened. But from my perspective in emergency medicine, I wanted to try to focus and ask the question, can emergency medicine be saved? Because I think as the lifeboat of our society, as the safety net, we can't as a society imagine the collapse and failure of emergency medicine. It would be catastrophic for our system. Well, it's concerning because on scores that are published right across North America, about half of emergency healthcare workers show signs of burnout. They score high on a burnout scale. And you might say, well, that's just a scale. But actually, it bears out in that 3 to 7% are leaving per year. So 3 to 7% of emergency staff leave their job each year, and it's not at retirement. The median age that people are quitting and leaving emergency medicine is 44 for females and 56 for males, which is way below the average leaving time from any other specialty. So in terms of research and how we contributed to this over the years, well, we've tried to focus in on some of these areas. We've done papers where we looked at burnout here in New Brunswick and actually found the rates to be very similar to the national levels. We have looked at interventions such as critical dynamics training to see if that could help reduce burnout. It did not. We have looked at the impact of age on preference for overnight shifts, which is thought to be a major factor, and we've seen that older physicians go to extraordinary lengths to swap out of their night shifts because of the impact it was having on their life and well-being. And then finally, we recently wrote a paper on this same theme of saving emergency medicine, focusing in on compassion and how compassionate care might be something to help us. So this was part of a series of 3, now 4 papers, the Saving Emergency Medicine series. And if you would like, it's easy to find. You can even Google it and you can find it on the Emergency Medicine St. John page. You can get open access to all these papers. We started off by focusing in on, is less more? Are we trying to do too much in our emergency departments? We then looked at how we train, and is there better training we could put in place? And finally, we centered in on this idea of compassion. The theory being from this series that for the system to work, and you can apply this beyond emergency medicine, this could be for any part of the clinical system, that it's almost like we have a Maslow's hierarchy of needs for the delivery of care, and that the first layer, the basic base layer that Maslow would have talked about, shelter and food, are the resources. We need the resources in place. You can't provide healthcare without resources, without space, without staff, without access to imaging. You then need training. You need to be trained in a way that is efficient and appropriate to the job at hand, not just some general training and then jump into a specialty job. We need to train people for the job they're doing. And finally, when that's in place, and only when that's in place, can you expect there to be this top layer, which is the higher thinking, but the higher purpose almost of the compassionate care. So yes, we must get there. We must deliver compassion, but in reality, without the adequate resources and with lack of training, it's very difficult to then get to achieving compassion in our care. But let's pause for a moment and ask ourselves, what is compassion? Well, this quote's from the Dalai Lama. Compassion is an openness to the suffering of others with a commitment to relieve it. So, is this necessary? Is there a problem? Is there a gap? Aren't we all compassionate? Don't we all care? Well, the studies would say that that might not be the case. And so 3 papers here from North America over the past quarter of a century, but the most recent one just being about 4 or 5 years old. Studies have shown that about half of patients feel that healthcare lacks compassion. When you actually analyze communication and dialogue, it's rare that compassion is expressed in our day-to-day interaction with patients. Less than 1% of dialogue includes compassionate statements, and 70% of opportunities to reassure and give compassionate interactions are missed. And it seems to deteriorate as we get older. And I've seen this for medical students, and that's much of the business we're in here at our universities is training medical students. They start off with great empathy and great compassion, but something happens. And so it's been shown that, in fact, 63% of physicians show on reports reduced empathy as they progress through their career. And you can actually track that down. So it is a problem. But as a concept, does it matter that it's a problem? Does caring actually matter? So let's imagine a 34-year-old unhoused homeless male presenting in early winter here in bitterly cold New Brunswick with frostbite to both feet. Now there's a medical issue there, and of course it matters. And so my question though is, does it matter more on the treatment he receives in terms of rewarming, reperfusion, or does it matter more that the team cares for this person in terms of his outcome? And I would propose that it might be that it matters more about the other parts of the care that are provided and not just the specifics about the science of his frostbite. What about the 60-year-old paramedic who reports that she cannot face work ever since she performed CPR on a drowning child last fall? In other words, she's been exposed to psychological trauma. What matters more here? Is it more important that she is trained in CPR, or is it more important that someone listens to her and gets her the support she needs for her career? And what about the 69-year-old female who reports that she's been having dizzy spells and she gets a major workup, cardiovascular workup? Again, which is more likely to help her, assuming it was normal? Is it the meticulous assessment she gets, or is it the care package and the compassion to make sure that her home is safe, she has someone to call, that she knows what to do? Which is more likely to get her to 79 in a healthy state? I'm not saying it's one or the other, but does caring matter? So I like to think about care in the biopsychosocial model, and this is something we use at WorkSafe a lot. And it's to think that every problem that presents to you can have multiple components. The biopsychosocial model, I think, speaks nicely to a lot of conditions, pain conditions, chronic health conditions. And I think we are not often as focused on this approach that as we should be or could be. We think a lot about the biology. We think about the cellular mechanisms, the pharmacology, the drugs that are required, the tests that are required. But yet, as well as that, there's the social elements to this, the family circumstances, relationships, the wealth of the person, the homes, the ability to afford whatever treatment that you are providing for them, their insulin or whatever other medications. And then there's the psychological components to it: pain thresholds, coping skills, social skills, mental health, mental illness, self-esteem, concentration, memory. All of these things matter in terms of getting good health outcomes. So that's great. We'll accept that there could be a functional psychological component to this, but what about the interplay? What about the interaction? Is it real? Is it not just these are all separate and contributing to the global health of someone, or are they actually interconnected at a deeper and physiological level? Well, it's interesting. I think most of us would be aware that some common illnesses can be caused and made worse by stress. Obviously, depression and other mental illnesses, there's certainly a component of stress related to that, as is PTSD with an acute exposure to trauma. Insomnia, cardiovascular disease has been absolutely tied to stress. For example, lack of sleep, stressful environments, night shifts, and the like. The common cold, there's great studies out there showing that you're much more likely to catch the cold if you're under stress. HIV and AIDS, again, you do worse if you're in a stressed environment. GI disease, multiple ties to stress. Chronic pain, even cancer outcomes have been shown to be impacted negatively by stress. And autoimmune conditions often flare up under stressful conditions. So this is evidence that negative psychological impact can impact disease. The ultimate one, I think, that I often point to, if anybody says, well, no, I don't believe that how you think or how you feel or the stress you're under actually impacts your physical state, is Takotsubo syndrome or stress cardiomyopathy, right? So the stressors include grief, fear, extreme anger, bereavement, surprise. And what can happen is this sudden, instantaneous cardiomyopathy where 2/3 to 3/4 of your heart essentially stops contracting, as you can see here in the left ventricle and the echo. And it's often known as broken heart syndrome, the wife who dies a week after her husband or vice versa. It's real. Because there are good and there are bad signals in the body, and this is making it very simplified, but I think it's reasonable to go down this. We have our sympathetic and our parasympathetic system. They're not good or bad. They have different roles in different situations. But there are also, if we go down another level, there are pain and reward systems, both in a neurochemical way to at a high level, right? So both within our neurological system and within our hormonal biochemical systems. And so these are clear and can now be mapped out on functional MRI and other brain scanning tests. And we can definitely identify reward and pain circuits in the brain, and we can see when these are activated. Pain versus reward. We'll come back to that. So this is great, but why study compassion scientifically? Can this be studied? I think often we think of compassion, empathy, sympathy as some moral virtue or something that's just an expectation from a professional approach. You got to do it. If you do, it's great. If you don't, it's not a big deal. But can it be studied as a measurable clinical intervention? That's the question. Does it function as a behavioral variable in patient-clinician interactions? And what about this theory that it actually can operate at a system-level property? Like, what about healthcare design? How important is compassion at that system level? You may have heard the podcast. You may have read the books, the Freakonomics books, where these two interesting economists from Chicago dissect everything and break down, what influences what. And so it's economics, the study of the economy and what influences it. Well, there's another book out there called Compassionomics. And so Compassionomics in the same frame is the omics of compassion, the study of compassion, not just the idea, but the actual study of it in a scientific approach. It's essentially a hundreds of pages long systematic review of the evidence. A little bit dry reading, but the idea in there is incredible. But let's just pause again and have a look at what compassion is and where it sits. Sometimes people can get a little bit mixed up between sympathy, empathy, compassion. Sympathy is defined here and by many as the understanding of others' problems, their grief, their suffering. We understand it. I don't feel it, but I understand it. I get it. Empathy is a little stronger. It's when you actually have an emotional response, maybe a physiological response. Empathy is when you cry, when you see a dead child, or when you see some of the pictures on television. And as that response goes down, you may maintain your sympathy. You can look at some of the terrible things that are happening, and you can say that's terrible, but we become almost immune to it. Empathy is when you actually feel that same response. You share that with the person who's suffering. Neither of those are compassion. Compassion is the next step. The compassion is taking that understanding or feeling and turning it into action. Saying, I understand what the problem is. I even sometimes feel it, but more importantly, I'm going to act. I'm going to do something about that. And that is what we mean when we talk about compassion. And compassionate healthcare, if we're going to start dissecting into this book paper by Tresiak and Mezzarelli, it actually makes a difference. And it makes a measurable difference. And it helps patients with outcomes. It helps healthcare systems. It helps us as professionals in the healthcare system. And there is a study that shows that it only takes 40 seconds of focused, compassionate intervention. 40 seconds. 30 seconds at the beginning of your interaction, plus 10 seconds at the end. And we'll come back to that. But that's not a lot to ask for something that might actually improve outcomes. So what are some of these outcomes that have been studied? Well, and this one shocked me at first, but in the same way that stress can have a negative outcome in healing, compassion has been shown to improve healing. And this has been demonstrated with improved wound healing times, with faster physiological recovery. It's been demonstrated to show better cardiovascular and autonomic function in chronic cardiovascular disease. There's lower inflammatory markers, measurable lower inflammatory markers with compassionate care. As an example, you might say, well, what do you mean? Well, in a couple of these studies, they actually went to the point that patients were given hugs, massage therapy, for something that isn't musculoskeletal. So you have a wound or you have measurement of a CRP because of an autoimmune disease. And as well as the usual care, they were given a caring hug, or in some of the studies, they were giving a compassionate interview where somebody spent time with them, short time, spoke to them, asked them about their fears, explained things to them. That's what we're talking about here. And that showed measurable outcomes. Reduced patient pain and lower need for analgesics. They were able to wean people off opioids with compassionate care programs. And importantly, higher adherence to medications and treatment plans. System benefits. Patients who received compassionate care had fewer visits to providers. They had fewer tests and fewer referrals. And you might say, well, what, 2%? No. In one study, the proportion of patients who were referred to specialists was almost 60% lower, and diagnostic testing was cut by over 80% when compassion was introduced into a care program. As well as that, it helps us, it improves clinicians' well-being, resilience. When you're providing compassionate care, it helps avoid that empathetic distress. So it is a good thing, not just for the system, but for us in our careers, and may help us stay in the game longer. So here's a bit of a conceptual model for this. Patients suffer. We deal with it all day. In healthcare, the patient is suffering. We recognize this as a clinician. We provide a compassionate response that is action-oriented towards the suffering. This leads to physiological and behavioral effects, and we see patient and system outcomes. So that is the concept of how this works. Some of the possible mechanisms we've alluded to already, but there may be psychological benefits, and there may be impact on psychological conditions. There's improved trust between the carer and the patient, reduced anxiety if things are explained better, and improved adherence to the treatment. There may be physiological benefits, as I mentioned, reduced stress and inflammation. There may be behavioral. We talked about communication improvements. And then at the system level, we see the benefits with fewer tests and referrals. So let's go back to this model. And there's a really interesting study where volunteers with a functional MRI were shown distressing videos, and they're given descriptions as well of distressing situations. And whenever they were unable to do anything about this, or it was unresolved, you see somebody falling, and then it's unresolved. You don't know what they land on, right? This kind of idea. Or you see somebody, they shoot, somebody gets shot or stabbed, or they're bleeding, and then it just cuts. You don't know what happens. You're not able to see a resolution. This led to activation of the pain thresholds in the brain of the people seeing this. So this is empathetic distress. They were worried and felt bad about what was happening, and this was measurable in the brain with pain responses. And this we know is associated then with stress, poor health, burnout, withdrawal. And I think this is often a lot of what we see in the healthcare system, where we've high volume of patients coming through. We don't really know if we've fixed them, or the patients who are waiting in the waiting room, we don't know if we've cleared their problem, if they're going to be safe, or if you're a specialist and they're on your waiting list and you're concerned because you haven't seen them yet and you don't know what could be happening. So that chronically can lead to empathetic distress. Whereas the opposite, if you show the same scenario, but you show a resolution where there was no harm or action was taken, and so there was an action to address the problem, this led to the reward center being lit up, the relief, the feeling of, oh, great, they fell off the cliff, but they landed in the water, not on the rocks, right? This similar positive feelings actually in oxytocin released that you see in when people talk about love. This is associated with good health. It's associated with less burnout, and it's about that's when you care for others and you get that feedback from that. So this is a positive outcome. People often challenge this. And they say, but if you go back far enough, didn't we all evolve by survival of the fittest? Isn't it all about competition, not helping others? Well, I think this is a distortion of Darwin's theory, and it doesn't really align either with many of the great cultures and religions which talk about helping others. But even if we're just going to stay on the science here, Darwin, in his thesis, wrote this statement that I think is often overlooked, and he was misinterpreted. He didn't actually ever say survival of the fittest. That was attributed to him. What he said was that communities which include the greatest number of the most sympathetic members would flourish best and rear the greatest number of offspring. So yes, it's survival of the fittest, but survival of the fittest communities that look after each other and look after the weaker members too. So we have to be careful in what we attribute sometimes to the great people and scientists of history. So on that same theme, you might worry that, well, this is a lot. I'm struggling myself, or I'm busy. Don't I need to look after myself before I look after others? There's actually some truth to this. So I'm not dismissing this. Two books that I will recommend on the right. One is called Give and Take by Adam Grant. The other is called Wonder Drug by the same authors as Compassionomics. And it's essentially a more sort of down-to-earth lay version of Compassionomics. It's more readable. And in both these books, they talk about this quadrant and the two axes. One, you're concerned for others, and the other, you're concerned for yourself. And the optimal place to be on this is to be in the top right, where you do have concern for yourself and others. So you give, you're compassionate, you help others, but you also draw a boundary and say, but I also need to take time for me to look after myself, my health, my mental health, my family, and not just give more than you have to a system that will just keep taking and taking and taking. And so there are failed givers, those who just give, 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 and never look after themselves. But there are also just the takers. There's the takers who don't care about others at all and just look after themselves. And they actually don't do great. They don't do well in their careers. We don't really like those people who just take, take, take. Of course, there are some people who don't do either. They don't really look after themselves. They don't really look after others. And often they are sometimes seen in some of our patients. And that can be very difficult to motivate people to look after themselves. Underpinning a lot of this is this idea of the social determinants of health. And I mentioned these earlier. I'll mention them again now. And there are many. So health is not just what we do here in the healthcare system, obviously. Most people are impacted by a much broader set of influences and circumstances that impact their health. And the earlier we can help with like childhood education and a good diet, or even going further back to some of the programs you might have heard of PCAP, where they look after pregnant women with addictions and making sure the fetus isn't exposed to alcohol or drugs during pregnancy. These things matter. They matter a lot. You're really predetermined for success sometimes before the age of 3. So it's important. Housing, income, education, security, transportation, social support, and access to care, which is a problem right now here in New Brunswick. So we studied this quite recently. In fact, the paper was just published 2 days ago, and I was able to put the PDF on the talk. We looked at social determinants of health in emergency care. We know that social determinants of health influence emergency department visits. Certain categories of the population use the ED more. We know that most clinicians recognize that it's important, but does it actually change what we do? That was the study, and it was a mixed method study. We looked at a survey of ED staff. We did qualitative interviews as well as a survey. We examined barriers, and we wanted to examine the gap between knowledge and practice. Well, what did we find? We found, and we were actually quite pleasantly surprised, that 93% of our staff understood the social determinants of health. That's most, essentially. but only 23% routinely considered them when they were coming up with a treatment plan. So 93% knew about them, but less than a quarter would routinely consider them in their care. When asked about why this was, well, time, I'm too busy. Staffing, I'm too busy and I don't have anyone who I can spend time with the person to talk to them about this. Workflow, if I spend more time with them, then the next patient will suffer, and that's real. And limited access to community services. So a lot of these social determinants require interaction with organizations that perhaps it's not easy to contact or you don't know how to contact them. They're not open in the weekends or the evenings. So there's a lot of issues with that. So the conclusion really was that we need a system support. People are aware, but they're not routinely considering a lot of these things that may actually help prevent the person returning early. One of these big things is time, and we published about time. It's another theme. Emergency departments and clinics and offices are busy, and patients wait a lot, and a lot of their time is empty, even though our time is full. And I want us to think about this. So we're busy as healthcare providers, working hard, doing stuff, but the patient is often sitting there waiting, and there's not much going on. So their perception of time is very different from ours. And so I think we have to remember that when we go in and we spend time with our patients, is that the proportion of their visit that we're there is tiny, even though for us it's our full interaction with them. And so we have to make the most of it. It has to be quality and it should be deliberate. It should almost be like you're going out to perform on a stage. I'm not saying it's a performance that isn't real or fake, but it needs to be practiced and thought through and structured. We need to understand why they're there. We need to look them in the eye. We need to sit at their level and listen. And so make those moments, that time that you spend with patients, more memorable and meaningful for them. And here's a few strategies that might be useful if you're a clinician. Leave behind the thoughts of the last patient. Clear your mind as you go into the next patient. Give them your full concentration. They may have waited 6 months to see you or 6 hours. Give them the concentration. Thank them for waiting. You don't have to apologize. It's not your fault they waited. It's the system, but why not thank them? It's a positive way to do that. Sit down beside them. Don't stand over them. If possible, smile. At least give the impression that you are here and interested in them. And let them tell their story. I love this statistic. On average, when uninterrupted, it takes 29 seconds for patients to describe their main concern. But typically, physicians interrupt after 11 seconds. So maybe giving them that extra, whatever it is there, 18 seconds at the beginning could be useful. And it's not a big burden for us to listen a little bit more. Look at them, listen, empower them, give them education, not just prescriptions. Involve them in their treatment plan. We have shown in another study that we've published that prescribing exercise in the emergency department leads to meaningful changes. So if you think that somebody needs to change their behavior, don't just tell them, write a prescription that you want them to walk 5,000 steps next week, 10,000 steps eventually. Give them a plan. Set expectations, explain timelines, and then finish by asking if they have any questions and did you cover their concern. People often fear that one. They just tell the nurse, oh, you can send that patient home, they're fine. Tell them their results are okay. No, go in the room, listen, close it off properly. That's important. That's part of compassion. That's part of being action-oriented. So that's the evidence that's there. We've contributed to much of this, but is there future research to be done? Yes, I think so. There are questions. How can compassion be measured reliably, not just in time? What interventions increase compassionate behaviors? Training, CPD, incentives. How does system design influence compassionate care in terms of how we organize our environment? And which patient outcomes are most impacted by compassionate practice? I think that still needs to be determined. So I think my key takeaways as we wrap up this presentation is that compassion, it's a clinical behavior, but it's shaped by system design and how busy we are and perhaps rushed and underfunded. But it does influence measurable outcomes that we've talked about, real measurable outcomes. And I think as a scientist, it's a very legitimate field for scientific study. So I'll finish off back to emergency medicine. We raised the question, can it be saved? And I don't think the question really is whether it can be saved, but how will we save it? Because I don't think we can afford for it to fail, or any of the other core specialties that we have in our system. And I think that compassion plays a part here. Compassion is not optional. It's the substrate of our work. It's often why we went into medicine or healthcare or science. It keeps us focused on the human in inhumane circumstances at times. So we'll close with a quote from Mahatma Gandhi: compassion is a muscle that gets stronger with use, so we need to practice it. And I want to thank you for your time. Here's a QR code that you're welcome to scan. It'll take you to some of the evidence, and be happy to take any of your questions. Merci beaucoup.
Wow, thank you so much for that presentation. Super fascinating. I was on the edge of my seat eating up all of the things you were saying. I'm not a doctor, but I could make references as a mom to some of the things you were saying. So thank you so much for that presentation. I will open it up to, if anyone has any questions, you can raise your hand and we'll go kind of in order of your questions. If not, I have some questions I could ask if no one has questions, but we'll give the opportunity to our public to go first, or if they don't, then I'll go first. Okay, then I'll go first. My question is actually, as I'm listening to I was listening to your presentation talk about what the healthcare providers, so doctors, what they can do, and sort of the list of things, and even like, you know, leaving the last patient behind and everything, all the kind of the list of things, and also thinking about what you were saying, that the healthcare professionals themselves are suffering from burnout and are suffering from, they need compassionate care too. And I wondered, you know, how do we help patients be more compassionate towards the healthcare providers, or is that even a thing? You know, I was thinking to myself as a parent, like the reference with my kids, like if I've had a rough day, they've had a rough day. Well, I'm the adult, so I'm supposed to be the one who, you know, but also I'm trying to educate them on how to have compassion towards mom and her day. So I was making that reference with patients. So I wanted to hear your thoughts about that.
Absolutely. I may give you a little anecdote, if that's okay, and then we'll go to the evidence behind it. So sometimes I do shifts in some rural hospitals, and quite recently, and again, I'm not calling anyone out, and we'll be cautious here not to divulge any privacy concerns. But a young lady was brought in, and she was known to have some mental health concerns. She was a user of substances. She had substance use disorder. And the police brought her in to this small hospital, and really it was unclear, you know, what the actual problem was. I think it was behavioral, but the police brought her in and literally threw her onto the bed and handcuffed her to the bed. This young lady was crying. She wasn't happy. And there was a female officer, female patient, thought, wow, maybe there would be more empathy there. I'm not sure. I'm not trying to be like, it's obviously not always about gender, but she was really aggressive. And so I thought, I'm going to have to be deliberate here in my compassion, because that patient is not going to be exuding warmth to me as I go in the room. So I really put on that extra approach of not fake, but genuinely went in. I asked the officer if there was danger. We got her unhandcuffed, got her sitting up, got her something to drink. and did all of that before I started asking her anything. I just wanted to show, and interestingly, she responded very well to that. And then a nurse came in, and we took that approach rather than going along with this, let's call a code white, tie her down, escalate it up. And I find more and more, and I think that's an extreme example, but I think the evidence would show, and it doesn't always work. So first of all, there is a true concern about violence towards healthcare workers that we shouldn't underestimate here. In fact, it's quite scary that, people have died, they've been stabbed, they've been shot. So we have to absolutely be safety focused, and I think every institution should have appropriate security measures in place, and we should be screening people for weapons if there's a concern of violence. And we don't really do a great job at that, but we should. But I also think that there's the other element of you have to make the circumstances right for the patients to show compassion, because they are the ones who are suffering, they're the ones in pain or have a concern. And so what can we do at a system level to make that better? What would the evidence say? Well, the evidence would say simple things like informing them on the wait time is the number one concern. They don't, you like just sitting there for hours waiting, or waiting for weeks, not knowing if you're going to see someone. Simply giving people the information. Say, this is going to be 5 weeks until you get your test, or this is going to be 3 hours until you see whoever. Number two, then, keeping communication channels open, not using the default, well, that's not my job, I can't tell you that. Trying to help people understand their circumstance, what can be done, offer them what you can do, work to the full scope of your practice in giving what you can. So I think there's lots of, and I'm no expert in the psychology literature field, but I do partner with some people in our studies who are, and there are lots of studies around how to improve clients' behavior in certain circumstances. And I think we need to look at those in healthcare, and we maybe haven't. We put people in a cold environment, crowded, a hard plastic seat with nothing to eat or drink for hours, and then we say, now I want you to behave nicely, and if you dare swear at me, I'll kick you out. But that's, we wouldn't do that anywhere else and expect that people to behave well. Even airports have comfortable seats, right? So I think just you know don't lump everyone in together. Look at the psychology science, the behavioral science, and let's try to make our systems a little more patient focused in terms of comfort and compassion. That's how I would answer your question, Julie.
Yeah, it's a great answer. Thank you so much. And I wonder too, I'll give the option if anyone else has something to say, raise your hand. But I'm curious about where you're at with bringing this work. I mean, your presentation is powerful. And I feel like there's more and more, even here at the au Centre de Formation Médicale, we have an elder in residence, and he often has talking circles, and he talks a lot about compassion in a different way, for sure, and maybe in a more spiritual way. But I feel like there's a focus now on training our doctors even younger while they're in med school to talk about some of these things from different perspectives. So I wonder where you're at with your work. You wear a lot of hats, you participate in a lot of committees, and I'm wondering, like, do you feel like you're making some headway to actually have some policy changes or to get things to be seen differently from decision makers?
I think I've seen some progress. You take the small wins when you can. There's I don't know how to say that in French. Is it I don't even know, le petit gagne. What's the small win in French? But
I would say small wins, so unless anyone
you
else.
you have to take it. But and little thing like when I was a department head in St. John and Emerge, we got comfortable padded seats in the waiting room, number one. We introduced bringing water around to people while they were waiting. We put in some materials for them to read. That was one thing. At an educational level, I take every opportunity that I can to try to promote this, written papers on it. But I agree with you. I'm not sure that I mean, certainly the curricula that we have at our medical schools now have professional competency classes, and they do deal with communication and empathy. But I'm not sure that we have made a breakthrough yet on this piece. I'm really not. but we have to keep trying. So the way I will say is, well, everyone who's here today, and there's 29 people on the call, I would ask you to think about this, because as I said, it takes 40 seconds at the beginning to make that effort to sit down, to listen, to look someone in the eye, not interrupt them, and truly listen. And at the end to say, have I helped you with your concern? Is there anything more I haven't covered? Even that simple intervention has been shown to improve outcomes. That was done in an oncology setting. So, I think we can do this and we can spread the word. And I think as we train residents, students, as we think about our science and our curricula, it's not a lot to ask to just build in a tiny piece about compassion, since that's essentially what the whole system was meant to do in the first place. So I think it's reasonable for all of us to take this away and think, not how can Paul Atkinson change people, but how can we? Because it's pretty cost-effective intervention.
Thank you so much. I think for me anyways, I can take this into my own life, even just listening to some colleagues for longer, taking things in. So for me, I've made lots of references. So thank you so much for your presentation. It will be available, ça sera disponible sur notre site web s'il y en a qui veulent le suggérer à d'autres amis ou d'autres personnes qui ne pouvaient pas être ici aujourd'hui. Ça sera disponible sur le site web. So thanks again, Dr. Atkinson, and wish you a wonderful rest of your day.
It's a pleasure. Thank you. Bye-bye.
Merci tout le monde.